ये कनेक्ट क्यों हो रहा है इससे? Can you check in? अच्छा, एक बार YouTube में चेक करो ना, आ रहा है कि नहीं कनेक्शन आ रहा है इधर? इसमें लाइव हो चुका है. इसमें आ रहा है, इसमें दो आएगा, उसमें EP को कल अलग रहता है, चैनल का नाम दूसरा होगा, हार्टबीट में सेकंड आ रहा है. यस, तो इसी पर काम चलाया जाए. All should have to open your YouTube channel for time being. Okay, giving that access. It's okay. Let us type them. कोटिश को बुला रहा है. छोड़ देना, वैसे ही फालतू बात करेगा उसको. YouTube में तुम ओपन करो, सारा इन्फॉर्मेशन उसी पे जाएगा. उसको बुलाओ ना. वेयर इज अरे बाबू, जितने लोगों को आज जस्ट फोन अपना ऑन करो, वीडियो सब उसमें जो दिख रहा है वैसा उसमें. चल सर, एक ग्रुप में भेजना सर. हाँ, भेज दो. ओके, YouTube में ओपन कर लो, सब लोग इन लोगों को लिंक दे दो जिसको ओपन करना है. Yeah. So good morning. This is our first class. It may be some hitches are there, but next time हो सकता है इसको we will be making better. And basically this is our preliminary classes regarding the EP to ablation. So basic preparation, how we do it, what are the steps we are taking, how the ECG has been interpreted, how we are going to ablate, all those things. If anybody who is interested for knowing the basic EP study and how we go and ablate by seeing the signals, this next classes will be very, very important. Whoever want, either they can join through the YouTube live, or if they want physically, they can visit Care High Tech, 5th floor, and this is the room. Usually by 8:15 it will start, and it may be 45 minutes classes. Today, the video will be today the presentation will be for almost half an hour, and we are all going to discuss some important points. So this presentation comes from the Heartbeat Foundation and Care Hospital, and you can open you are able to see in your videos. Yeah. So ECG to ablation. This is the one of the important what you call program from the organization. And what we are going to do is the basics of EP study, normal conduction system, baseline measurement, and approach to EGM reading. So these are the things on which we will be discussing today. I think lights will be on. रहने दो, इसको कौन देख रहा है? इसको रहने दो. Face is coming ना. So when you come in the anytime if you have come in the our EP cath lab, EP lab, which is very unusual. A lot of lines will be coming, colored lines up and downs, and we usually say, okay, block. Now it is blocking. These are the two words commonly used. Conduction is happening, and sometimes block is happening. And it is very difficult to understand what is happening. Means what, even when I have completed my DM, I was not able to understand what they are doing it. So in that situation, how to read it, how to start it. I have read almost 10 to 15 books before going into EP, from simple to difficult, and I came to know that no book starts with the basics how to start the EGM reading, means how the monitor we have to read. That has never been taught in any of the standard book. They will be only discussing regarding the conduction. There's sometimes the channelopathies. But when coming to the basics, means these are the things you have to see first, then next. These are the usually methodological way of anything. So when I struggled for this, I thought, let me make the thing simple, because if somebody know how to walk first 2 steps, he can run also. So running every book is writing, but how to walk, how to stand up is the most difficult part, where the most of the textbooks are not giving any information. So if you see the video point of view, it is written ABCD, all those things, but if you are going to see in the picture, it is written read between the line. So that read between the lines, the so many informations are there. What information you have to gather, you have to focus on it. So focusing will come when you know where to focus. Okay, so that makes the difference. So if you can see what exactly it is, anybody? Are you able to see? In the video, you should see something is coming. I think they have. Network issue is also coming. Okay. Right now, where we are? Focus. After focus, there is one image will be coming. You can come in the front line. Yeah. After focus, some eyes will be coming. Okay. So you are able to see the eyes. Then lips is coming, and finally the face. So if you want, I can. Is it okay now? But yeah. So basically, when we are, I was going back. So what I was saying, how to focus it. So we have to keep a focus by seeing this eyes. Anybody can predict who sees. Then we have given the second clue, and after that, it is very easy to do. So sometimes we have to focus only one thing, and we can predict what next is going to happen. The same thing is when we are reading the Asian, we should be knowing from where we have to focus. So in AP lab, we do three things. The first thing is called pacing, second thing is called recording, and third is called ablation. So these are the three steps. When you are seeing the patient has been taken, we will be first recording the basic parameters. Second comes the regarding we are going to pace, see the how the conduction is happening. And third, when we have identified the what you call abnormal pathway or substrate, we are going to modify. Means we are going to give the heat therapy we call as a RF ablation and come out. This is a total three step. But in this, when we are putting the lead, you can see one here, second, third, and fourth. These are the four catheters are there. This is in the right atrium upper. This is the His catheter. This is the coronary sinus catheter, and this is the RV catheter. This is very important when we are using the word distal and proximal. Distal means it is at the tip, okay, and proximal means this. So this normal, most of the time people are not able to identify. Even you give a catheter and say where is the distal, he will say distal it is this one. But what is the number? 9, 10. But it is not. So I wanted to say to everybody, proximal will be having 9 and 10 number. Distal will be having number 1 and 2. Is it clear now? So when we are saying proximal to distal conduction, proximal means 9 and 10, means here 9, 10. And when we are using the word, please. When we are using the word, when we are using the word CS 9, 10 means coronary sinus 9 and 10. When we are using RA 1 and 2 means, RA 1 and 1, 2 means distal or proximal. Yes, very good. And when we are saying RA 3 and 4 means? Yes, very good. So this is distal, this is proximal. Same time when we are saying his 1 and 2 means? His 1 and 2 means? Yes. So it will be here. And his proximal means? 3, 4. Okay. So coronary sinus will be having the highest number of poles. So DECA, yes, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Usually DECA 10 is the DECA, 20 is the duodeca. So normally in our labs, or most of the lab all over India, we use DECA for the CS. CS is going to take all the information from the coronary sinus, and coronary sinus lies at 40. Coronary, तुम वहाँ बैठो, तुम उधर नहीं बैठो, sit there. You are able to see? Yes. Where the coronary sinus will be? Location of coronary sinus? LV posterior. Okay. Correct? It is at the junction of left atrium and left ventricle. Okay? On the posterior surface. So this is like, this is RV, this is LV, this is LA. The junction between these two is the CS. Okay? It is on the posterior surface of the heart. So this catheter is lying there, and this is very critical. Critical for what? You are getting two information in one go. What two information? Atrium, ventricle. When you are putting in the, here this catheter is in the right atrium, it will be giving only right atrium information. When it is keeping in the right ventricle, it will be giving only right ventricle information. But when you are keeping in CS, it gives two information. One is the right atrium, one is the right ventricle. Okay? So this is the CS catheter. And after that, out of all the catheter, if you have to say only one catheter I have to use, which is most critical, what is that catheter? His give all conduction, atrium, ventricle, and AV conduction. All three can be coming on this one. So this is the most important what you call the catheter which has been positioned during the EP study. Atrium, ventricle, and in between how the conduction is going, it is been going to be captured by the skeleton. Okay. So when we are using the word pace, so all will not be pacing here. The distal will be pacing most of the time. So distal is pacing and proximal will be gathering the information. Means it is going to check the how the conduction is happening. Okay. So first is the conduction. We are going to study what is the time taking from upper chamber to lower chamber. All those parameters are there. We have to measure it. After that, we have to make some decision. Okay, this area is having abnormal conduction. We call it the pathway. We call it the substrate. And after that, we'll give a heat therapy. So pace, record, and ablate. These are the three uh, things which we are doing in the EP procedure. So this is a normal conduction system. This is the AV node. After that, this is the SA node, and these are the RA and RV. And after that, Purkinje system. So this is a very common system that, and how the conduction system is working, you can see. So this is the way the whole conduction will be normally going on. Each and every bit will be going like this one. It has always has to pass through the AV node and then go down. If it is bypassing AV node, then we call it as aberrant conduction or abnormal pathways. If it is not going from this one, it is going from this one, abnormal. It is going from this one, abnormal. So it has to go through node, after that his, after that right and left, and then Purkinje's. This is a normal pathway. Now, coming to the basic concept of ECG and EGM. This is very, very vital. And what exactly ECG and what is EGM? There are two words we use. Anybody? ECG, full form?
ECG,
very good. What is EGM?
In EGM, seeing the rhythm also.
Okay.
Like the wave junctions, we will be able to see these.
Okay. Anybody more to add it? Koti, you are the EP guy. You are not saying anything. Swapna is saying all the ECG. What we are surface electrical activity of the heart. Okay. So when the electricity is reaching to the above the chest wall, or you can say on the body, through the heart, means heart is producing, it is reaching to the body, and we are measuring it in an integrated way. Means the current is going like this one, that one, but it is finally the atrial activation, ventricle activation, all are happening at a different time in a different direction. So it is an integrated electrical activity of the heart which is reflecting on the surface, which we are capturing through the ECG machine. So this is surface, means outside the heart. It is indirect measurement. Okay. When we are taking the EGM word is electrogram. Means
from the inside of the heart.
Very good. So we have kept some catheter inside the heart, and we are taking the local information. Okay. So India word we are using, and we are saying, okay, this is Telangana, this is Andhra, this is like that. All the different territory we are taking, and after that we are making, okay, it is India. Is it clear now?
Yes.
So when we are saying India means it is the just integrated part of the. But when we have to give information, where is Kerala? You have to say, okay, this is Kerala, this is Andhra, this is Telangana, this is Odisha, like that, all information. So that is called localized electrical activity of the heart is called electrogram. It is taken by the intracardiac, or you can say intracardiac catheters. Is it clear now?
Yes.
So both are giving different information. One is giving integrated information, okay, how the current is flowing in the heart. So there is a P, then QRS, then T. But when you are coming in the EGM, there is only lines. Tuck, 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 tuck. These are the things. Sometimes big, somewhat small, like that. How much current is there? There we are not getting the directionality, okay, how the current is flowing. There the directionality we see how the catheters are positioned. Okay, the catheters are positioned at this. It is coming first this one, second this one, third one. Like that, we find the temporal, means over the time how the current is flowing. But when we are seeing the ECG, it is already reflecting. First the atrial activation, then the time has taken, then ventricular activation, then ventricular repolation. So these are the things we are seeing. Is it clear now?
Yes.
Next class I will ask it. Don't worry. So CSP. P means P means good. D means तो इसका नंबर क्या होगा? What is the number for CSD? इसको क्लास से बाहर करो. 9 and 10 किससे होगा? D means distal means distal means 1 and 2. Yes. This mistake should not happen. D versus P. This confusion will be there. D means always 1 and 2, and T means 9 and 10, or 3 and 4. Okay. After that, how many catheters must be there to get this information?
4.
How you know? Tell me. Swapna is expert here. I was not expecting this answer from Swapna. Okay, tell me. How you are saying that the 4 catheters are there?
Just how you showed in the image.
No, in this one, this EGM we have taken. How you are knowing that 4 catheters has been used?
The way that the graph is showing the measurement.
See, you are correct, but
In
how?
paper.
Yeah. So 1, 2, 3, 4. There are 4 catheters because right atrium EGM here. Okay, this is his proximal and distal means there are 4 poles are there. After that CS EGM, that is having proximal, mid and distal like that, and finally the RV. So there are 4 catheters. In our EP lab, how many catheters we are using? Huh?
Sometimes 4 also used.
4 you are used there. We usually use up to 3 only. So which catheter we are not keeping? Tell me. Koti? Huh? RV?
I think he said.
कौन कौन सा कैथेटर यूज करते हैं? Tell me what are the catheters we are commonly? No, where we are putting the catheters? No. So you are not oriented. Okay, now onward you should start seeing it. We are not using RA catheter. We keep RV, his, and DECA mean the CS. And we start from कहाँ से start करते हैं? RV. We want to see conduction कैसे हो रहा है. Okay. So RV is the first. Whenever we are going to SVT, RV. When we are going to VT, RA or CS. CS and RA is equivalent because CS also gives the atrial information and atrium also gives the atrial information because it is at the junction. Na? So this is one of the important thing that it is an integrated electrical activity on the surface of the heart. The surface of the chest we are identifying by the different leads. It may be unipolar versus bipolar. Here again we are having a unipolar versus bipolar, but it gives the information regarding the localized electrical activity where the lead has been placed. So that is called electrogram, not electrocardiogram. Okay. And this is the thing what we see. So you can see this is we are able to see how we are reading the EGMs. EGM के time में हम लोगों ने this is atrial. How is which is atrium, which is ventricle? Anybody can say? With the back. Where is the atrium? Where is the ventricle? Anybody can guess? So this was the thing what I was saying. The four catheters we have kept, and this is the way we start seeing the ECG. Are you understanding
Yes.
what I want to say in this one?
Which one is the RA?
Which is atrium, which is ventricle. So AV. Always we are going to check this one. And so you can see this part. So this is the P wave. Okay, this P wave is going down, and when you are seeing the RA, right atrial activation is happening first because SN is in the right atrium. After that there is a his. Then it is you are seeing the his A, H, and V. There are three waves are there in the his. Okay, are you able to see?
Yes.
So from activation is started from the A is at the his. Now this is the CS. CS is lying on the left atrium. Left atrium. So the left atrium activation is happening third number. So RA, his, and left atrium. During the normal sinus rhythm, this should be there. Okay. This is the second, the his, and then this is the ventricle, ventricle. And then this is the catheter which is kept in the ventricle, means it is showing the only ventricle. I know it is a lot of things will go on, don't worry. So, but you should know how to identify it. This is again ventricle. Getting this point? QRS, and this QRS is having the same pattern. There is a two waves. So CS is the catheter which is having two waves. When we are putting what immediately say, sir, you are in the CS. When we are getting only one line like this one, we will say, sir, you are in the right ventricle, not in the CS. Our technician will say, sir, you are not in the CS. When we are getting two waves, and one wave is a very crisp wave, one is having some broadness, we say that we are in the CS. Okay. So that is the way identifying. So whenever you have to read, you have to start from the surface ECG. Okay. Surface ECG come the intra, means we have to come from outside to inside. ECG reading, X-ray reading, EGM reading, there are rules that we have to always and always follow. You have to start from a methodological way. If you are reading the X-ray, you have to start from outside to inside or inside to outside. When you are either way. When you are reading the ECG, the same thing is going to be applied. You have to start with P, then PR interval, QRS, T, and after that all the intervals. Like that, there is a there is a methodological way. I've already taught in the last few classes. So same thing has to be followed here. When you have to read the EGM, you should not directly start focusing on this one. Okay, sir, this yes. You have to start surface. Where is the P? So this information means it is the A. So P is equivalent to A. P means atrial activation, and A means so when the activity of the you are taking activity inside the heart, we use the word E. So this in the EGM it will be A, and this is called V. V means ventricle. When you are reading on the surface, you will be saying P and QRS. Is it clear now? Surface whenever atrial ventricle. P waves, QRS. When you are reading in the EGMs, you will be saying A followed by V. In between, you will be getting his. Okay, only in the his catheter. Now you can see in this what is there. Anybody can read. Is it easy or difficult? Koti, batao. What you are getting in this one? Hmm? When you are reading, you have to identify the surface wave, A wave, his wave, and this. And activation is, this should be the normal you should be knowing, otherwise you will not be able to identify abnormal. So first of all, this whatever the wave form will be, it will be going at very fast rate. So what we have to see, P followed by QRS, A followed by AHNV, AHNV, like that it is going on the his. And here again, you can see one important information what I want to impress. So here the line is, so here the line is very crisp. Are you able to see or not?
Yes.
And here it is somewhat like it is wider. It is not as crisp. This we use a terminology what you call far field and near field. This word will come. So when we are saying far field means the whatever the information we are taking, the catheter is very near to that chamber. When we are saying far field means the electrical activity is still gathering but from the distance. So when we are keeping the CS catheter, it is more near to the atrium and far from the ventricle. But it is a junction. It will take both the currents. You can see here this is the far field A, the far field B, and this is crisp A. So this is one important information by which we say, okay, we are more. Sometimes it will be more wider and this is more crisp. Then we will say that is CS catheter is more into the one of the branch of CS. Okay, and then we will say, sir, you draw the catheter, it is coming like that. So this is way we are seeing, and you have to see always HRA, high right atrium is first, and from the low atrium, and then this is the left atrium. So activation is happening from right to left. Okay, and followed by again there is a his and then there is a V ventricle. Okay. So again, same activation pattern you have to see, and this is the way we have to go. Okay. Why we do the EP study? Kotesh, why we do a EP study? Okay. So the answer is there. We want to know the basic measurements of basic measurement for what is the normal conduction is happening or not. So it is a SA node automaticity. We use SNRT, sinus nodal recovery time. AV conduction study we do means how the AV conduction is happening. It is blocking. Blocking means the conduction is not happening at the average, whatever. Means if a 18-year-old boy is not able to walk for half an hour, half kilometer, means he is diseased. A same person who is in 70s is not able to walk for 500 meters, it is normal. Is it clear or not? So when we have to measure, we have to see, we are seeing what is happening with the AV conduction. It should be, for the young patient, we are expecting that the AV conduction will conduct up to the rate of, if the heart rate will go around 180, 190 also, it should be conducting. Okay. But if it is blocking at 120 means AV is not proper. So that is called AV NRP. Second is the AV conduction, means whenever we are giving, when we are pacing, we want to see there is a conduction is happening from SA, AV, his, and right bundle, left bundle, and this conduction. But if it is happening from the aberrant path, means something coming from the different, we will be using some other words because of the eccentric activation, concentric activation, all those things will be coming and we will be discussing. And the conduction is not happening from the atrium to ventricle, it is happening from ventricle to atrium also. Okay, so that part also we will be doing. And the second part of conducting EP study is induction of arrhythmia. So why you want to induce arrhythmia? Tell me. Why you want to induce arrhythmia? Doctor, you tell me. Why we want? See, one patient is having arrhythmia. Why you want to bring the arrhythmia? Tell me. Till DM, I was also not knowing. Don't worry and don't get shy. There's nothing wrong in that. So when I have completed my DM and I asked, my friend was I can say my friend was the person who was doing the EP study and RF preparation. So are you having arrhythmias? No. So okay, well, he's having palpitation and I think 1 or 2 times he is having he has taken medicine. I'm like, yes, he is taking medicine. I'm like, why don't you update it? Like, no, there's no protocol like this one. We have to bring the arrhythmia and then we have to study it and after that we have to update it. So the reason of bringing the arrhythmia means induction means you have to bring the arrhythmia. You are a good person or bad person, where we are going to prove you? In the court of law. Somebody has said you are a whatever you have done some stealing or something like that. Some allegation has been kept. So in the court of law, what we are going to do? There is a two-party. One will be saying, okay, he is the criminal. One is saying he is not a criminal, and we are going to prove. Same thing we do in the cath lab, or you can say EP lab. We bring the patient. ECG is there on which we say, okay, he was having the arrhythmia, no doubt. He was given adenosine, he has recovered, he has gone home. Now, from where it is coming, why it is coming, that we have to identify. For that, we have to bring the arrhythmia again in the EP lab to decide from where the location is. Okay, location we are not knowing. We are knowing the mechanism that it may be a reentry arrhythmia. It is coming from the upper chamber, lower chamber, but exactly where is the location? 90% time we will be bringing in the cath lab or EP lab, and then we are going to study it. Study by some protocol. If it is going like this one, means this is the diagnosis. If it is going like this one, the diagnosis is different. So like that, the characteristic of the arrhythmia is going to be tested in the EP. Is it clear now? So arrhythmia has to come in the cath lab or EP lab. If you have not brought the arrhythmia in the EP lab, means you have not done the EP or EPS RFA. And that's why the big job for Kotesh is to ask the patient, have you taken the medicine? Oh, you have taken. No, it can't be done. 3 days later you should come. So 3 to 5 half-life has to over of the medicine before taking the patient to the cath lab. Okay? So if a patient is taking beta blocker, minimum 3 days to 5 days, you have to stop it before taking the cath lab. Otherwise, the arrhythmia will not come because it is suppressed. Cardron, he has taken how many days you are going to stop? Cardron, doctor, your good name? Mohandas. You are in which department? Huh? Oh, city anesthesia. Okay. So what is the half-life of? What is the half-life of this one? Cardron? Anybody guess? 1 day, 10 days, 20 days, 30 days, 50 days? Huh? Huh? It is 39 days. 39 days. What I remember, confirm it once more. And what I remember, it is very long half-life because it will be there in the fat tissue. Whatever amidron you are taking, it is going and depositing. So when you are not giving from fat tissue, it will be coming again to the blood. So initially you may have seen that when we are giving the medicines, IV loading. So when you are loading, it is not in the blood. After a level of blood, it is going and spilling in the fat tissue, and it will be sitting there. So we are giving 1 gram over 24 hours, then 200 milligram for next 5 to 7 days, and then 200 milligram OD, then 200 milligram half tablet is 100 milligram OD, then alternate day. So first we give big dose, which is called loading dose. After that, we start because we know that body is already accumulated. The same thing. So when patient has taken amidron, and if you are going for EP study, and patient says, "Sir, I have taken for at least 15-20 days," you have to wait for at least 1 month before taking it. So amidron 1 month. If you are beta blocker, 3 to 5 days you can stop and you can start the EP study. where you have not to see that whether the patient has taken or not. What are the conditions where there is no need of stopping the medicine, you can directly take the patient. Yes, anybody? Huh? Hmm? Yes, come forward. Patient on the antiplatelet. Okay. Anything more? Yours name? Subhas. Hmm? Tell me, Subhas. One Subhas is forward, one is backward. Not fast. Hmm? So, the thing is, when the patient is having atrial fibrillation, there is no need of stopping the medicine because atrial fibrillation is a mechanical. We are not going to bring the arrhythmia and check from where it is coming. Most of the time, what we are going to do, we are going to pulmonary vein isolation. So we are knowing the anatomy. We have to just do some work and come out. There is no need of knowing the circuit there. So there is no need. Second is if the patient is in atrial flutter. Most of the time the circuit is we are going to reduce and we can terminate all those things. So if the patient is ongoing atrial flutter, no need of even the patient is on medicine, it is means if it is arrhythmia is running, means second is arrhythmia is running, atrial fibrillation and atrial tachycardia on medicines, any medicines with tachycardia, you are not to stop, you can take it, do it. If the baseline is sinus or the baseline is atrial fibrillation or third WPW. Okay. So WPW, usually what we are expecting, we are knowing ECG wise from where the problem is. We have already decided this is a left lateral pathway or right lateral pathway or it is a septal pathway. All those things has been seen by the ECG only. So there we know where to avoid because the abnormal conduction is already happening in the baseline. Is it clear or not this point? When patient is in sinus rhythm, if there is no aberrant conduction or we call as a WPW syndrome, there is no conduction thing which is visible on the ECG on the conduction also, conduction study. But when the patient is having delta waves, means abnormal conduction is visible in the baseline ECG, and when you are going to do the EP study, the same location is also showing the current leak, what we call as or abnormal conduction. So you can identify aberrated over. Is it clear or not? But ideally, 3 to 5 days medicine, if you can stop, it's good. So atrial fibrillation and WPW syndrome, where the delta waves are visible, you can even the patient has taken, you can give attempt to ablate it, or you can do the EP study. Okay. So in the EP study, what we are doing, baseline conduction measurements should be made in. So there is one language we use in the EP lab. What are the languages? Written, na? No. Milliseconds. Suppose in kilometer, millimeter. So here we are only using millisecond. There is no rate. 128, 130 rate. ऐसा कुछ नहीं है. Only and only millisecond. So this language we have to learn. If you are saying 600, 700, 900, 1000, 200, means 200 milliseconds. Heart rate of 60 means what is the cycle length? 1000. Yes. So same thing. That is the first thing we have to use it. That measurement in the millisecond, basic cycle length BCL or we can sinus cycle length. That is the second measurement. Third important parameter AH interval, how much time it is taking from A means atrium to reaching to the his bundle. And fourth is the information. This is the basic condition study what we have to do it. And this is the way we measure it. So when the 1000 is there, means 100 is 60. You can see 60 into whatever multiplied will be coming 60,000. 60, 60,000. 100 into 60, 60,000. 12 into 50 means 500. So it is just when the heart rate is 120, means the cycle length will be 500. When the heart rate is 150, the cycle length is 400. And when heart rate is 200, means cycle length is 300. And when the heart rate is 300, the cycle length will be 200. So like that it goes. Okay. So this measurement we have to do, and most of the time below 200 we not means cycle length. When we are pacing also, na? So pacing cycle length will be starting from 500, 400, 300, 200. After that 200 will be stop. Most of the time after 200 we don't go because what will happen? Yes. So when you are giving two, means you are pacing at a very fast rate, sometimes if you are pacing from the atrial fibrillation, you are pacing from the ventricle, sometimes patient will develop VTVA also. So we have to be careful not to go below 200. 200 heart rate. 200 means the cycle length is around 300 milliseconds. So first of all, we don't use the word 200 beats, we use 300. So below 300, usually we don't prefer to go. But for the ventricle atrium, we can go up to 250, 220. And this is the measurement what we will be doing. AH interval and HV interval. How to measure H and V interval? Kotesh, it is for you.
Starting from H.
Yes.
And ending from V.
Hmm?
Starting from V.
V. Where the V you are going to measure? Which V?
CS prime.
CS proximal. तो निरंजन के साथ इतना बैठता तो कभी पूछा नहीं उससे, हाँ? Okay. So this is one of the most important, what you call vital parameters in the EP, HV interval. HV interval prolonged means some complication has happened. HV interval is prolonged in the baseline means patient needs pacemaker. HV interval is small, low at the time means patient is having apparent contagion or WPW syndrome. So all information is revolving in and around HV. So one if you have to remember that is of HV interval, and that HV interval is 35 to 55. If it is going below 35 means short. Sometimes it may be negative also, and if it is going above 55 means the time from the AV node to going outside is taking too much time. Means his is disease, bundle is disease. So this is the AHV. AH is not that important, but HV is very, very important. HV is prolonging means something is going wrong. And V is surface ECG. That you should remember. It is not the V. The word we use V, but the V is not the intracardiac V. It is a surface QRS. So you can see the H and followed by the whatever the earliest PQRS first complex is coming, that is called V, not the inside. Okay. So you have to be on the surface ECG. What I was saying is HV 35 to 55. 75 plus is the mark for the patient to go for the pacemaker implantation. What are the conditions when the HV interval? If it is short, there is the most important condition we call the ventricular pre-excitation, WPW. In that it can be negative also. PVC, that is catheter recording, and whatever when you are putting the catheter, his catheter has moved to towards ventricle and it is taking the right bundle. And long HV is in his Purkinje system disease. So this is the intracardiac ECG. Okay. You will not get this type of ECG when you will be doing EP study. It is only in the diagrams you will be getting. So you can get the A, H, and V. But when you will be seeing in the EP lab, it will be like a small one. But where to see that you should be knowing. You have to see the his catheter. Okay. So this is A, this is H, and you can see V. Okay. So like that we have to measure it. AA interval is giving the atrial cycle length. AH interval gives the AV conduction time, and HV interval gives the his Purkinje conduction time. Okay. The same, whatever we have discussed, that HV interval. In this, one important information is whenever you are measuring the his can be sometimes proximal and distal, which when we are using not quadri, we are using the octa catheters. So it will be giving his proximal, his distal, and we are going to measure what is the distance between this. If the distance between the his proximal and distal is crossing 30 millisecond, we say intracardiac, intrahesion block. Okay, and this is a whatever conduction study when we will be discussing that time here. So this is the job that now my favorite colleague Kotesh has to do in the coming time in the EP lab. That is the baseline electrogram recording, and that you have to do pre and post for all patients. What you have to do? Pre-EP, BCL. You have to write down BCL. What is the BCL? You know. What is the PR? What is the QRS? What is the QT? PA interval, AH interval, HV. You have to measure. When you start the EP study, you have to write it. And when you complete the EP study, then again you have to write all those things. Sometimes you have to write before isoprene, after isoprene. So this measurement you have to do it. And in this, the one measurement that is called the PA measurement. P means surface, P, and the height of all the patient. And accordingly, we have to. So how many catheters are there in this one? इतना टाइम लगा तो लिखा हुआ 4 catheters.
4 से.
Anyhow, you can see this is one is the decapolar in the CS, one is the RV, one is the HIS, and one is the RF. Okay. We usually do three. We take out this one, this catheter. We don't keep it. So we take whatever measurement we can measure from this one only. How the normal activation will be. Okay. So normal activation. Now you can start reading P followed by QRS. Uske baad, next what you have to see, where the first activation is happening. First active activation is the HRA. Then it is his. Then it is CS. It is happening or not here? You are saying?
Yes.
So this is going in the normal direction. So it is a normal sinus conduction. Okay. This is the first measurement, AA measurement, what we call as BCL, basic cycle length. We have measured it. इसमें भी नहीं आ पाएगा. Anyhow, we are at the end. Let me check after that also. Then this is a baseline interval, AH interval, how to measure it. Start from A and his. Second is HV interval. Now you will be able to measure it. Okay. Third is called the HV interval, normally how much it is, and HV more than 100 anytime, which is indicated for putting the pacemaker. So thank you so much for your attention. I think this was our first class. It may be possible that we will be revising, but somebody has to. I've asked one person. Swapna will be next time. She is very active, so she will be giving the first presentation, first 4 slides regarding this one. How much she is able to understand. Night duty नहीं रहेगा ना उस दिन. रहेगा भी काम रहेगा. आज हम शायद अंदर में बाहर से भी देखें. कम. हाँ. Go. Thank you.